Well, there are many factors that have led us to where we are today in this opioid epidemic. First and foremost is our concern, physicians' concern, to treat pain and suffering in our patients. And so that coupled with the lack of a true continuum of alternatives to treat that pain, with a lack of payment for many alternatives to opioids. And I also think there's something to do with the fact that we are a bit more disconnected. Our communities are a bit more disconnected. So I think there are many factors that led us to where we are today, which is why it's important to not look for that one single solution, but to really focus on a multidisciplinary, interdisciplinary, all-in approach, comprehensive approach to address this problem.
So,
Well, I won't make a prediction on the time that it's going to take, but I will say a few things, and I have been saying a few things. The medical community has been saying a few things. We know that systems like Augusta University have been looking for alternatives to pain, of course, non-opioid alternatives to pain. That's one solution. The other solution is for those who currently have substance use disorders. We have to make sure they have equitable access to treatment. We know in this country the statistics show that only 2 in 10 patients who seek treatment for opioid use disorder, the gold standard for that is medication-assisted treatment. You may have heard about that. Only 2 in 10 patients have access to that treatment. And so we really have to make sure there is equitable access to treatment for opioids, as well, again, as the non-opioid, even non-pharmacologic. We know there are surgical interventions and other interventions. Our anesthesia colleagues are looking forward and working on this. So we have to make sure folks have access, which means we have to eliminate barriers such as prior authorization. We have to make sure that insurers and our state insurance commissioners are making sure that parity is not just a law on paper. So again, many ways to address this, and we have to address them all. We need a public health focus to solution and a comprehensive systemic focus. But I will say that systems are best when they are tailored to the local community. We have a tendency to want to come up with one magic solution or one-size-fits-all solution, and it really is going to be very different in different communities. So we have to take that into consideration as well.
what are some?
Well, this is a problem across this country, but we know maybe in certain areas the problem is different. I will say, and this is important, this epidemic has evolved. Initially, we were focused on the overdose deaths because they were mainly due to opioid medicines that were used to treat pain. But now we see that most of the opioid overdose deaths are related to fentanyl, and even some of these stronger carfentanil. These are anesthetics used for large animals. So carfentanil, illegally produced fentanyl on the street, and heroin. And so that's why it's important to have the public health community have the data and the surveillance, and they can spot areas of use, and they can spot what substances are used, and then the medical community and the academic community, we can go in and then design solutions. But again, it's hitting everyone. It knows no bounds, it knows no socioeconomic status, it knows no race. This epidemic is hitting everyone. Well, I am president-elect, and that just happened in June, but I've been chair of the AMA's Opioid Task Force since 2014. So I've had the wonderful opportunity to lead the AMA's efforts on this, as we've convened on that task force representatives from state medical associations and national specialty associations. And we've come up with 6 recommendations that we believe demonstrates physician leadership and shows how physicians can do our part to address this epidemic. And I'll just quickly go through them. The first one was certainly to register for state PDMPs and use those. Not perfect tools, but Nevertheless, they can have valuable information to enhance and increase our education on opioid use disorder, on pain, to also work to increase access to treatment. And we even recommended to anyone, but particularly our primary care colleagues, to get certified to provide that office-based medical assisted treatment in their offices. Fourth is to reduce the stigma. Of course, that's not physicians' responsibility alone. Actually, none of this is, but we want to do our part to decrease the stigma. The fifth recommendation was about increasing access to naloxone. And I have to say that really almost all 50 states have enacted legislation to enhance access to naloxone. And the sixth recommendation was regarding safe storage and disposal. We want to make sure that physicians talk to our patients, and our patients know that when they receive these medications, they should make sure that they are stored safely, so that they are not to be used by anyone else, and that they are disposed of properly. And here I want to make mention of a program out of the Medical Association of Georgia's Foundation's Think About It campaign. It's a very nice campaign raising awareness and education for not only physicians but for patients as well. You ask about solutions and how we turn the tide of this epidemic, and it's clear that we have to do it together. This problem does not belong to the medical community alone, the academic community. We do need public health. In fact, there's also a role for law enforcement in this too. And so it really is important for community groups, community-based organizations, certainly our federal and state policymakers. As I said before, this is an all-in solution, and we don't reverse this epidemic without all working together. Well, here's what we want to make sure that when used appropriately and when used as prescribed, opioids help our patients. Here's what we don't want to do in our, what I say, appropriate zeal to address this epidemic. We don't want to leave our patients who are experiencing pain, chronic pain, out in the cold. We have to make sure, and certainly we want to be judicious in our prescribing. We only want to prescribe opioids when the benefits outweigh the risk, but we also want to make sure that we have appropriate treatments for our patients in pain. Opioids can be an appropriate alternative, but you've also heard about the work going on here where there are other alternatives. So we want to make sure that we use opioids appropriately, judiciously, but when they are appropriate, when they are working for our patients, when they are restoring function. Now, I think we have to get away from that 0 to 10 scale, but we have to talk more about function and quality of life. But again, when they are used appropriately, they are a good tool, but they are one tool, and they should be used cautiously. And we should make sure we have the other alternatives available so that the decision between the physician and their patient can be made based on what's best for the patient. Well, as you may know, naloxone reverses an opioid overdose. So you are talking about right then and there when a person has overdosed. Naloxone is critical. It's a life-saving measure. And again, all 50 states have passed legislation or enacted policy to increase access to naloxone. So that's what we want to do right then and there. And we want to make sure that naloxone is not only in the hands of the person who may be at risk for overdose, but perhaps even in the hands of their family members or their relatives. And we encourage physicians, the AMA and the Opioid Task Force encourages physicians to consider co-prescribing naloxone for their patients who they think are at increased risk of overdose. So that's right there in the acute episode of the overdose. Then we know that there are many folks who need treatment, who have an opioid use disorder. And so we want to make sure they have access to treatment again, so they discontinue using and can lead full productive lives. So that's sort of one step back. And then the other issue is prevention. And that's where the education comes into play. That's where alternatives to non-opioids for pain comes into play. And so, and that's where, again, reducing the stigma comes into play, so that patients who have chronic pain or have substance use disorders and are having difficulties can feel comfortable talking to their physicians about that. So there are many paths to get to reducing the number of overdose deaths, and it has to be all in, and we have to continue our work on that. I do want to highlight the need for treatment. I mean, I think that is a huge gap at this moment, and we need to make sure that there are resources available for treatment. And then the other issue that you heard me just touch upon is stigma. We need to be very careful, even with the words that we use. People that have substance use disorders don't have a moral failing. It's not a character flaw. These are brain disorders, and we have to make sure that we treat substance use disorders in the same manner that we treat any other chronic illness like diabetes or high blood pressure, with compassion and with care.
We are facing nationally a crisis with opioid diversion and overuse. To the extent that we're summarized statistics are telling us that we're losing over 40,000 people per year due to opioid overuse. So it's a national crisis. And Dr. Harris joined us today to increase awareness around this crisis with our healthcare providers, and to also begin to contemplate solutions, not only at the national but also at the local level. It's very concerning because of the statistics that I just shared with you. And in terms of the perioperative medicine environment, I believe that we have significant opportunities based on new evidence to decrease the amount of opioids that are being used in the perioperative context. Most recent data are suggesting that for a patient who might be susceptible to develop opioid dependence, 3 days of post-operative opioid use is enough to create that dependence. With over 50 million surgical operations and procedures in the United States, I think we have a tremendous opportunity to rethink how we're treating pain during the perioperative continuum. Here at MCG, in collaboration with our surgical colleagues, our colleagues in nursing, pharmacy, respiratory therapy, you can see it's a multidisciplinary process. We're beginning to standardize the way we treat our patients in the operating room and after their procedure when they remain with us as inpatients. For example, we now have patients who undergo colorectal surgery. This is a big operation, and they never receive opioids during the operation or post-operatively. So this is really a chance for us to look at multimodal ways of treating pain in the post-operative period that is not opioid-based. So we went through, as in many areas in medicine, you see treatments come and go, and we have heavily relied in the past on the use of opioids as one of our primary treatment modalities for acute as well as for chronic pain. If you look at the number of opioid prescriptions from 1991 to 2011, they more than tripled to about 210 million. So we were in the habit of prescribing opioids, one opioid prescription for almost every adult American in this country. To give you a little bit more background, the United States makes up about 4.6% of the world population, but we were using well over 80% of the total global opioid supply. So this is rapidly changing with awareness, and we're realizing that the opioid crisis to a significant extent was created by overprescribing, having opioids in your kitchen counter, sharing it with friends. So that awareness has, and Dr. Harris will be able to speak to that in more detail, the habit to prescribe opioids is going down in our statistics, right? So we're prescribing much less than we have in the past. So that is significant progress. Now, on the other hand, we have to be careful that the pendulum doesn't swing too much to the other side, and that patients who require opioids, terminal care, as an example, still get their opioids and are not left in pain. But there are many new ways of treating pain without the use of opioids. So for chronic pain, for example, is radiofrequency ablation, neuromodulation approaches, epidural steroids. These are all non-opioid based therapies. In the area of acute pain, we're able to treat with nerve blocks, gabapentin, Tylenol, non-steroidals, lidocaine infusions, ketamine infusions. So these are all non-opioid based alternative ways to address pain. So our contribution is, we see our contribution mostly in the perioperative continuum of care and focusing locally but also nationally at the 50 million surgical procedures and operations, which does create an opportunity for us to take a hard look of how are we treating pain and do we have opportunities to get to less opioid-based treatment alternatives.